Okay, so now we're going to talk about Chapter 39, which is assisting in reproductive specialties as well as urinary specialties. So the learning outcomes here will basically go through how the medical assistant will deal with a specialty of both gynecology and obstetrics, as well as urology, which is both male and female urologic systems, as well as fertility or reproductive systems for males. We'll talk about some of the diagnostic and therapeutic procedures for both OB-GYN, obstetrics and gynecology, as well as urology. Okay, and we'll talk about a few of the diseases, and there's a little section in there on sexually transmitted infections as well. So to start out with, obstetrics means pregnancy, so that is the specialty that studies or takes care of pregnant patients. Gynecology is the female reproductive system, and so a lot of times you'll see that tagged or together as OB-GYN. When we're dealing with the urologic specialty, we are dealing with both the male and female urinary systems as well as the male reproductive system. So we'll talk about some of the things that we would do in those specialties. There are very frequent medical assistants that will deal with both of these, especially obstetrics and gynecology. However, there's a lot. Urology is it's not a primary care specialty, but it overlaps a lot. And so frequently you'll see medical assistants working in the urologic setting as well. And so being familiar with all of the tests, the disorders, and different treatment regimens are going to be important, as well as the diagnostic laboratory tests that are done is important. Okay. So at first, when we're assisting with a gynecologic patient, definitely a needed capacity. A lot of primary care physicians, a lot of OB-GYN physicians will want help or want to stand by as far when we're dealing with gynecologic patients. So we'll kind of talk about that in class as to how to assist with that. We're looking at some of the words and terms that go along with it. Menstruation is actually the term used for a normal cycle, okay, where we're actually having a female going through a cycle, preparing for conception or just preparing for a menstrual period. The word menarche means onset of period, so that means when a female actually starts their period. And if you're in a gynecologic or obstetric setting, that is an important word. We didn't talk about that as being an important factor when we're taking a history, but if you're dealing in a gynecologic setting or an OB-GYN setting, that is an important question, because it can, if somebody's late or early, it could show that there's some hormonal issues. And so prototypically 11 to 12 is kind of your normal age bracket, but it can be as early as 9 or as late as 16 or 17, depending on the activity status and the nutrition status of the particular patient. Periods are generally once a month, prototypically. Everybody's a little bit different. The normal quote-unquote average is every 28 days, and that cycle range comes from the first day of one period to the first day of the next period. It isn't measured from the last day of one to the first day of the next, so a cycle should be 28 days between the first days of the cycle starting. It can average anywhere from 3 to 7 days. Some are a day or two longer, some are very short, and then the flow could vary to mild, moderate to excessive. And so a lot of times you'll have to ask, if somebody comes in complaining of bleeding, they'll say, well, how many pads are you using a day? And 3 to 4 pads can be normal, but if somebody is soaking or saturating more than that, it can indicate that they're bleeding heavily. Okay. And so the word menopause means cessation of menstrual cycle. Now, this is very different with each individual. Some people will start having hormonal changes or menopausal changes as early as in their late 30s, early 40s. Generally, 50 is the average age, with 45 to 55 kind of being that natural time frame where things start to slow down or change. So that's basically your natural menopause time frame. And it can sometimes follow female relatives in your family, but not always. And so people can sometimes start having hormonal fluctuations a couple of years before they actually start having any changes in their menstrual cycle. If someone has a surgical situation where they have a hysterectomy or an oophorectomy and have their ovaries removed, then you can, with resurgical menopause, which can be rather abrupt and start pretty immediately after the surgical situation. you can go through different stages. You have sort of a premenopausal, a perimenopausal, and then a postmenopausal. And so the premenopausal and peri can last sometimes years. Other times it's very quick for some people. They just suddenly stop having periods and they don't have any hormonal changes. Everybody's different. The postmenopausal period is considered post when they've gone a full year without any bleeding. And so if somebody comes in and they are kind of having a period every 3 to 4 months and they're 49 or 50, that is normal. But we consider someone post-menopause when they actually go an entire year without bleeding. So if somebody goes a year or two and then starts bleeding again, that's usually a key. We'll usually work those people up with uterine biopsy, ultrasound, pap smear, and make sure that there isn't any cause for that bleeding. So that is definitely something that is a significant piece of information when taking a history. So we look at the gynecologic exam. We're basically doing an overview of the woman's health. Some women only get there; they don't go in for pure, for actual physical exams with a general practitioner or a family practitioner. A lot of people just go in for their gynecologic exam, and so it's important to kind of make sure you're looking at the woman's overall health, especially if you know that that woman is pretty much just using the gynecologist as their primary health care provider. So it's important to make sure you're screening for diabetes and cholesterol when it's appropriate. Cancer screening and exams the book is a little bit different. The book is a little old in the time frame, and so when we look at cancer screening exams and tests, they do talk about, when we talk about females, we'd be talking about a mammogram, and prototypically we start mammograms at age 40, and then usually they're done yearly. There isn't a stop time frame on mammograms at the moment. Some people have said that 70 at some point might, but we haven't actually. The American Cancer Society has not actually come through with a time to stop doing mammograms. We actually look at pap smears as our other screening exam for cervical cancer. The updated 39.1 talks about some of the guidelines for that. However, we've actually updated that. This book's a couple years old. Prototypically, we start doing pap smears at age 21. The book says 3 years after sexual activity. Generally, we still don't start until 21. Even if someone starts having sexual activity at 15 or 16, we would definitely do routine sexually transmitted infection screening and that, but pap smears usually start at 21, and then they are done pretty much every 3 years. Okay, the book says 3 in a row and then going to 3 years. The reason why standards have changed a little bit is because the updated pap smear testing methods are in a liquid-based and not generally done on a slide. And so if you're using the liquid-based, you can go to 3 years. If someone is still using a slide method where they're sending it off to the pathologist, then you would have to maintain the yearly screening exams, because that method is not as accurate and you can miss things. And so that's why for a long time we actually did pap smears every year, because we were using a slide and a pathologist read it. But now that we've gone to liquid-based that are much more accurate, we can actually spread out our time frame. Some family practitioners will still say, because they're in the habit of doing yearly, that they still need to. But if they're doing liquid-based, 3 years is plenty. I think even Kaiser goes to 5. So generally, you're going to do any time from sexual activity, anytime from when they become sexually active until at least 25. You're going to do routine yearly screenings on chlamydia, and sometimes you'll add gonorrhea to that. We do routine screenings from 18 to 26. It's in our protocol that we automatically do it. I mean, if somebody swears that they're not sexually active, we sometimes bypass it, but prototypically that's done. HIV screening should be done. We do at least one lifetime screening, but obviously that could be altered depending on the patient. If they're sexually active and multiple partners and not using protection, then you'd have to draw that as needed depending on the risk factors. Pelvic exam and cervical cytology, once again, are going to be done. You can do the pelvic exam yearly, but prototypically the pap smear is done every 3 years. Pelvic exams can go up to age 65, and generally that's a stopping time for when we'll not continue with the actual pap smears. If somebody has has had normal pap smears and they hit 65 and they're still with the same partner and there's no symptoms, we can actually terminate doing the actual pap smear. Sometimes we'll still do a pelvic exam to check the uterus and the ovaries, but the pap smear can usually be stopped at that point. And so when we actually look at setting a patient up for the exam, generally because it's more comfortable, it's better to have an empty bladder. So the thing you have to know is you need to know what your patient's there for and what their complaints are. You can have them empty their bladder. However, if they have urinary tract symptoms, you'd want to get a clean catch on them. If they've missed their period or think they might be pregnant, you would want to get a urinalysis to check for a pregnancy test. If someone wants to have screening STIs done for gonorrhea and chlamydia, you can do. Non-symptomatic patients can have a urine test done. There is a DNA polymerase chain test that can be done on the urine. Prototypically, those are only done if a patient is non-symptomatic or asymptomatic. If someone has symptoms, it's better to do the full pelvic exam and actually do cervical cultures as opposed to doing the urine. Okay, so you want to provide them the appropriate gown. If they're doing a breast and a pelvic, then they need to be completely undressed with a vest and a lower gown. If you're just doing a breast exam, then you can get them undressed from the waist up and use the vest that we talked about in class. You can have it open to the front depending on what your provider likes. But it is important to make sure they've removed their undergarments. A lot of women kind of will still leave their bra and underwear on, and so you sometimes have to be kind of specific because they're embarrassed. And it's one of those things. I frequently go into a room and they'll have their gowns on, but they'll still have their underwear and bras on, and I'll let them keep it on there while we talk, and then I'll exit for a minute and let them finish undressing when we're done talking. So the interview is really important, making sure you get accurate vital signs and know what you're dealing with, because sometimes there's multiple facets that are going into this exam. Birth control methods, last menstrual period, are they trying to get pregnant or not? And so making sure that, they might have sexually transmitted infection symptoms or bladder symptoms. And so, before you empty that bladder, know what you're dealing with and know whether or not you need to have some form of a urine specimen so that they don't empty their bladder and then suddenly the physician or clinician orders a urinalysis and then the patient can't go. And that happens sometimes. And then we've talked about the LMP. That is an important question at this point, whether it's family practice or whether it's in a gynecologic setting. LMP stands for the first day of the last menstrual period. It's definitely an important thing to write down. If somebody is more than 30 days or is more than one cycle late, it's usually a good idea to order a pregnancy test. Now, if they have a long-term method of birth control, like the Implanon, or the IUD, they might be skipping periods, and then it isn't necessarily as important. It will depend on the clinical necessity of it. But if somebody's not using birth control, they're using condoms or even pills, and they're a little bit late, it's better to go ahead and order it because you don't want to miss a pregnancy. Okay. And so when the physician actually enters, the physician will be looking at the total health of the female, not just necessarily the gynecologic issues, although that's the focus for that particular visit, but you have to look at the overall patient's health. You do have to look at the risk factors for cancer, breast cancer, uterine, ovarian, or cervical cancer, as well as possible of sexually transmitted infection. So generally you're doing a pretty thorough sexual history on these patients so that we know what we're dealing with as far as risk factors go. Generally, they'll do the breast exam first, and if somebody's on their period, you can split up their exam and do the breast exam on one day and then bring them back and do the pelvic exam. We do that sometimes. So the breast exam, you will get lots of questions on the breast exam and how to do it, and so there is a page in here that talks about how to perform a self-breast exam, which is called a BSE. If someone is being examined by a clinician, then it's called a CBE, or clinical breast exam, so there are two acronyms that are kind of important. When you're checking for lumps, generally you're going to do an inspection visually first to make sure that both breasts are symmetric. There are some people that have congenital or at puberty, one breast developed more than the other. So if it's something that's been present since puberty, it's usually normal. But if somebody has dimpling in the skin or changes in the skin color or changes in contour that have that were new, then it would be something that's important to look, to note. And so we kind of talked about the breast exam a little bit. You want to do a visual check while they're sitting up with their arms on their waist and then above their head, and then generally you'll lie them down, and you're going to put one arm, whatever breast you're checking, you're going to put that arm back behind the head, and then you're going to do a complete breast check, including the supra and infraclavicular area for nodes, as well as the axillary area for nodes, because the breast tissue does go into the tail of the breast tissue goes into the axilla, so it's important to make sure you check there too. So being familiar on how to instruct patients on a self-breast exam is important. Prototypically, we like to do it right after the period's over. You want to wait a couple of days. That's when the hormones are at their lowest level and the best time to actually do it. Mammograms start at age 40 and then pretty much yearly from that point. There are some guidelines as to certain things that you would want to recommend as far as when they're actually getting a mammogram done. If it's just a routine, they'll just order a baseline screening or a routine mammogram. Prototypically, it's better to get a breast exam with a clinician before someone goes in for their annual mammogram, just so in case they know what they're dealing with, because if there's a suspicious lump or mass, then generally you want to order a diagnostic. So if it's a routine screening, that generally means there's no symptoms from the patient and no mass is felt from the clinician. If there is something felt, then you kind of want to have a palpated view of what you're dealing with, so that the mammogram can go in and isolate the area and see, because some things can be felt and not seen on mammogram, and other things are vice versa. There are some small microcalcifications that you can't feel on a breast exam, but you can see with a mammogram. And so that's why it's important to do monthly self-breast exams, yearly clinical breast exams, as well as yearly mammograms starting at 40. That's the best way that you can try to prevent or try to catch something ahead of time. Okay. There are certain case scenarios where there's a strong family history of breast cancer, and then there is a specific kind of MRI that can be done. Prototypically, this is with a strong family history, and it has to be ordered. Patient can't just go in and say, I don't want a mammogram, I want an MRI. There are certain conditions with it, but it is available for people that have a higher family history risk. Then we get to the pelvic exam, and so in the beginning you're going to do sort of just a general inspection. You're going to look at, there's two sets of glands in the vaginal area, the Bartholin's glands and the Skene's glands, so you always want to palpate those areas and make sure. Some people will have chronic reoccurring Bartholin cysts, and so that is something to note and deal with if necessary. And then we showed the instrument that's used during this exam called a vaginal speculum. That will be inserted inside the vaginal area so that you can see not only the vaginal walls, but also visualize the cervix. So the cervix is the opening or the neck part of the uterus. You cannot see the outside of the uterus or the inside of the uterus just doing a pelvic exam or doing a speculum exam. You'd have to actually dilate the cervix and then insert something inside to actually get a specimen from the uterus. So ideally what we are checking for is either vaginal issues or cervical issues, primarily cervical cell cytology or cervical cell changes. Okay, so you can also do, you can check the vaginal discharge, and they talk about the wet mount in the book. You can prepare a wet mount or a KOH slide and check for the types of vaginal cells that are in there, the epithelial cells, and you can check for abnormal epithelial cells that are consistent with bacterial vaginosis, or yeast infections or trichomonas can be detected by checking or analyzing the vaginal discharge. You can also do cervical cytology for gonorrhea and chlamydia at that time. And so those can be done. Once again, you can do a urine on someone when they're asymptomatic, but if somebody is having symptoms or has possibly had contact with somebody, it's better to do the cervical cultures. After you've done the inspection and the speculum exam, then you remove the speculum and do what's called a bimanual exam. And that's actually palpating with one hand on the top part of the suprapubic area, and then one or two fingers internally to check the size of the uterus and also the ovaries. It's sometimes difficult to palpate the ovaries, but if you feel one and not the other, it's generally a good idea to check that out and get an ultrasound done. A rectal exam can be done at that time as well. Generally, you would take your gloves off, re-glove with something, a new set of gloves, and then a digital rectal exam can be done on a female at that time. Since we're not checking the prostate, the person doesn't have to be lying face down. They can be up. You can be looking for hemorrhoids or any other abnormalities that could occur. You can also do an occult blood at that time, and we'll talk about that in class. So right there it's listed. The pap smears, KOH, and wet mounts can be done at the same time, as well as other STI infection screening. So draping is important. Trying to maintain as much privacy. You may need to assist the patient in a position. Some people really struggle to get into the lithotomy position, and so they sometimes do need help. Some practitioners want to have a medical assistant in the room to help not only assist the patient, maybe hold their hand, or also help them do the pap smear. And so a lot of them want everything handed to them, and then so sometimes all they'll do is the actual pap smear itself or cervical cultures, and then they will hand everything to the medical assistant to do, and they will actually take care of it. So we'll talk about that, kind of how to assist in class, but that does happen sometimes. When you're looking at a colposcopy or an endometrial biopsy, you almost always will have an assistant because of the nature of the procedure, and it's really important to have a second set of hands to help do that. But the pap smears really can be done alone, but frequently practitioners will ask someone to assist with that as well. So when we actually get to the obstetrical patient, remember these patients are pregnant, and I'll show you what a pregnancy wheel looks like. You can actually figure out the estimated date. EDC, which is not listed on here, but an EDC is an estimated date of confinement, which basically is the date. It's kind of funny that it's called confinement, but that's actually your due date. And so there's something called Nagali's rule, which can give you an estimate of the delivery date, and you can actually calculate that by looking at the first day of the last menstrual period, and if you subtract 3 months from that month, you add 7 days, and then you add a year, you can actually come up with the estimated date of confinement or the due date. And I'll show you, I have a couple wheels that you can do the same calculation, but you can't actually do it if you don't have a wheel available. And there's a couple, they talk about it in the book, and I think there's one question, I think it's either on the quiz or the test, that just guesstimates, gives an LMP and try to figure out what the EDC is from Nagali's rule. So when we look at prenatal care, there's different things that the book talks about as far as different staging when you're dealing with the first trimester, second trimester, and third trimester. Eating well and exercising is important, and that can be something that you end up having to talk to the patient about. There's usually nutrition guidance as well. Exercise is usually okay. Whatever a person was used to doing before, for the most part within reason, is still kind of okay to continue with. There are some things that might not be comfortable for a woman to do, although I've seen women at 36 weeks doing aerobics, but it has to be what that person's used to. You don't want to start anything too overtly new. Abdominal exercises are usually not recommended after 5 months because the uterus is starting to get larger. So there are some exercises to do for the transverse abdominis, but prototypically you're not going to do your routine crunches or things when you're pregnant. Medical appointments is important to people. Sometimes wonder why they have to be there so frequently, but it's really important to monitor the growth of the fetus, and so it's really important to stress to the patient how important all the medical appointments are. Prototypically, you'll have your first visit between 6 and 8 weeks, and then you're generally going to see them every 4 weeks until they get to the 7th month, which is once you hit about 28 weeks, they start seeing you every 2 weeks. And then at 36 weeks, it generally starts going weekly. And that last month is really important because things like gallbladder stasis and preeclampsia and pregnancy-induced hypertension need to be watched for, and so that's why they have to go in so frequently. Childbirthing classes are usually recommended for at least first-time moms. It doesn't hurt to go through it with every pregnancy because it gives you a lot of info. Generally, once you've been through it once, you kind of know what to expect. Sometimes the first time it's a little scary, but it doesn't hurt to put women into that mode and having the reminders. And so advising patients to attend some form of childbirthing classes is important. Tobacco, drugs, and alcohol are definitely important to stay away from. Things like Tylenol can usually be taken safely. Benadryl, if they need sleepiness, or if they need something to help them sleep. There's a couple of things that are okay to take, but it's always important to make sure you clear that with your primary care or with the obstetrician. Things that can be normal. There's a page in there. Table 39.2 talks about a lot of the normal stuff that can occur. There's a ton of stuff. For those of you who have been pregnant, you know that. Morning sickness is sometimes not in the morning. It can be all day long, and it can sometimes be more than just the first trimester. It can go into the second and third trimester. Weight gain is prototypical. Generally, healthy weight gain is about 20 to 25 pounds for pregnancy, about 5 pounds more or less for the first 20 weeks, and then theoretically you could gain a pound a week after that. As long as you stay in that 20 to 25 range, usually you'll lose about 15 to 20 pounds with the delivery. So that's kind of healthy weight gain. If somebody's underweight, there can be issues. If somebody's overweight, there can be issues. Constipation and or diarrhea can happen because you've got a uterus that is growing and putting pressure on the intestines. It can disrupt the bowels. And so that is something that is very common. A lot of women have to wind up on stool softeners in order to go to the bathroom, but that is also very common. Urinary frequency. Some women feel like all they do is pee all day long and at night. And once again, there's more blood volume because you have to support the baby and the baby's growth. The blood volume, the red blood cells go up a little bit, but the plasma almost doubles, not quite, and so it ends up increasing the load on the heart. The pulse usually goes up a little bit, so people sometimes feel like they have palpitations, but that then causes a lot of urinary frequency. And so that is very common, as well as swelling. You just don't want to swell too much. A little bit of swollen hands and feet can be normal, but excessive swelling could indicate preeclampsia, so it's important to watch that. You can have mood changes. When you're pregnant, there's a lot of estrogen raging, and it can cause a lot of sensitivity and crying spells. But prototypically, depression shouldn't occur, but you can have some minor mood swings, okay? Depression really generally isn't normal. If somebody has depression before they get pregnant or develops it during pregnancy, then it would be important to make sure that you're screening for postpartum depression, because there's an increased risk of postpartum depression when you have pre-existing depression or you develop it during the pregnancy. Almost all women are screened postpartum for depression just to be on the safe side, because sometimes even if you didn't have it before, it can still occur. So make sure you take a look at table 39 too, because that kind of talks about the normal changes. I didn't mention everything in this thing, but there's others that are common. Frequency of prenatal appointments, I might have said this already, but prototypically you're going to get your first exam between 6 and 8 weeks, more or less, by the time you actually have a positive pregnancy test and get the appointment. It's usually between 6 and 8. And then you're going to be seen monthly, every 4 weeks until you hit 7 months, and then it's every 2 weeks, and then the last month at 36 weeks is usually weekly. Very important to make sure that patients know that schedule and that they adhere to it, because there's a number of blood tests that have to go along with that and screening tests. And so if they get off kilter, it can make it difficult to catch up with all of their routine stuff. Important things to monitor: weight gain, because if you're gaining too much weight, it can be a problem. Or once again, if you're not getting enough, that can also mean that the baby's not getting enough nutrients and maybe the baby isn't growing. Usually the baby will take what it needs, but then the mom can then be affected. Muscles and bones and what have you can be affected if the mother's not eating properly or is underweight to begin with. Blood pressure, very important to monitor. Pregnancy-induced hypertension is a true entity, and it must be monitored because it can cause severe issues with both the mother and the fetus. Every time the patient comes in, they're going to have their urine tested for protein and glucose. If the body is becoming stressed from the pregnancy, it'll usually start by showing in the urine. And what'll start to happen is that the kidneys will get stressed, and so you'll start having proteinuria. So that's why the urine has to be done every visit, because you're trying to be proactive and see if there's any proteinuria developing, because that can indicate that we're getting either pregnancy-induced hypertension, or the mixture of those two, protein in the urine with high blood pressure and swelling, can equal something called preeclampsia. And so that is an extremely important disease process to watch for, because it can be significantly an issue for both the mother and the fetus. Generally, women are going to take prenatal vitamins. It's really better to be on vitamins before you get pregnant, because that first 3 months is where the majority of the neurologic development's occurring. And so I try to put women, even if they think they might be trying to get pregnant, or they're not using any birth control and they're, kind of maybe trying, but it's okay if it does and it's okay if it doesn't. I'll put those women on prenatal vitamins ahead of time, just because you want those vitamins on board to decrease any kind of genetic or vitamin deficiency related issues. Iron might be taken if the person's anemic, and so it does happen a lot. Gestational anemia is a common thing because of the fact that the blood volume goes up. You get almost a doubling of the plasma, not quite, but the red blood cells don't go up as much, and so it can cause women to become anemic. And so we screen for that usually initially, and then again at 7 months, and then give iron accordingly if that develops. Things to look for during the pregnancy. Gestational diabetes is one of the big things that we screen for. We usually do a screening during the first trimester when the patient does their intake, and then we recheck it. At 7 months, prototypically, because that's about the time when someone will start to develop diabetes as the stomach gets larger. That can be where gestational diabetes begins, and so that's when we actually get an abnormality in the insulin the receptors change, and so we can't absorb the sugar as well, and so that we can actually see something called gestational diabetes. 2 other important things to look for are placenta previa and abruptio placenta. The placenta previas can usually be seen on an ultrasound, and so a lot of times early on the placenta will actually start to develop and it'll be obstructing the cervix, and a lot of times it will, as it matures, it will kind of retract up and move out of the way, and so it's not an issue. But sometimes when the placenta settles, it'll actually be near the cervix, and if it's partially obstructing, you could get painless bright red blood, so you do have to watch out for that. If the placenta is completely blocking the cervix and that's confirmed as the patient enters into the 3rd trimester, they generally need to have a C-section, because you can't pass through when you've got the placenta there. But generally the bleeding pattern with placenta previa is usually painless and kind of bright red. When you actually have an abruptio placenta, this is more serious, where the placenta actually separates from the uterine wall, and so you can actually get not only vaginal bleeding, but there's usually pain associated with that. So this is more serious. It's more common in the 2nd trimester, but things like motor vehicle accidents can cause it to happen too. So that is something that has to be screened for. When we've gotten to the 3rd trimester, and we're dealing with labor and delivery instructions. You have to always tell the patient, they have to know when to go to the hospital. So there's certain contractions called Braxton Hicks contractions. Those are sort of preparatory non-labor contractions that can start as early as 20 weeks. So those people will come in complaining of kind of hardening of the stomach sporadically. Water consumption is really important. If they walk too much or overdo it or don't drink enough water, you'll get more of those contractions. Those are listed in the table on 39.2. However, when we actually get to the 3rd trimester, and we're dealing with the actual contractions that are going to lead to labor, we actually start looking. These precautions are generally given at 36 weeks. We want to make sure we get all women to 36 weeks. 38 is preferable, but if they hit their 36-week mark, generally you'll have contractions 5 to 6 per hour for at least an hour or 2. And if that happens, generally they need to start prepping themselves to get to the hospital. If anywhere along the line the water breaks, that generally means that labor is going to happen pretty quickly. It's within hours to maybe a day, and so it's important that if anybody's water breaks, they need to go straight to the hospital and not wait. Okay. When you're doing with preterm contractions or preterm labor, which is below 36 weeks, they'll usually say if somebody has 4 to 5 contractions in an hour, they've rested and drank some water, and those Braxton Hicks aren't going away, then they'll usually have them go to the hospital and get checked to make sure we're not dealing with preterm labor. So when we look at the delivery methods, we can have a natural delivery, which would be a normal spontaneous vaginal delivery. You'll sometimes see it acronym NVD. Those patients usually go through a natural labor process. Sometimes you have to have help. Sometimes a vacuum or other assistance might need to happen, but it's still considered a natural birth. The word induction means having to induce labor. And so there's case scenarios where somebody goes over their dates, or they have pregnancy-induced hypertension or preeclampsia, and you have to actually go in and get the baby. And it's better timing to make sure that child's over 36 weeks because you want to make sure the lungs are developed. However, there are times where the baby needs to get out. And so there are actual tablets that cause cervical dilation, and so if they need to, they can actually insert Cervidil or some sort of cervical pill that can actually cause local dilation of the cervix. Then they'll follow up with something called Pitocin, which is usually an IV form, and that kind of increases contractions as well. So that's a way that you can actually induce labor if necessary. If that induction fails, or if there's another case scenario where maybe the baby's breech, maybe the baby's feet are down or butt is down instead of the head, or if there's a placenta previa, or there's a failure to progress where the baby can't, maybe the bone structure won't allow the baby to get through, or the cervix doesn't completely dilate, then there may be case scenarios where you actually have to have a C-section. We'll actually prep and have to do a cesarean section to get the baby out. Oftentimes you won't find medical assistants in the labor delivery because this is hospital-based. It's still important to know the process of things. Medical assistants sometimes function to schedule inductions and C-sections in the hospital. I suppose you have to always think of the fact that if you work in a gynecologist office or an OB office, you might have to do an emergency delivery. That could happen. But all the scheduling is important, and timing and dates are very important as well. Breastfeeding is important. That's another thing. We oftentimes have lactation consultants in the hospital, and some clinics will actually have availability of lactation consultants, and they can really be helpful when a woman is struggling to breastfeed. Breastfeeding is natural and normal and always advised, but it's not always as easy as everybody makes it out to be. It can be difficult to get the baby to latch. And so you want to try to encourage breastfeeding as much as possible. The initial milk that comes out for the first couple of days is called colostrum. There's a lot of antibodies in there and contributes to the passive immunity that the mother gives to the infant. And so even if you only breastfeed for even for a month, is better than nothing. And so you always want to try to encourage it, or even women that have to go back to work, making sure, helping them get a decent breast pump is sometimes part of what the medical assistant has to do, and help show them how to use it and go through that whole process, because it can be a little bit cheaper to have that breast milk, plus there is a lot of antibodies that are passed. And so once again, there are breast specialists or lactation consultant specialists, but sometimes I found some medical assistants will oftentimes go into that area, and I've seen some migrate from medical assisting into OB case managers and lactation consultants, okay? And so knowing the community resources in your area, the local hospital resources, is important, because this tends to be breastfeeding questions and issues are extremely numerous, so it's important to know that. Bottle feeding obviously sometimes works too. Some people manage to solely breastfeed and then maybe transition to bottle feeding, or do both. There's a lot of people that do both, and the bottle, the formulas that we have now are definitely good and a good alternative if somebody can't breastfeed. There's a number of different kinds of formula preps, soy preps, Enfamil, Similac. There's a lot of different ones. They come in pre-concentrate form, pre-mixed, and then they also have powdered stuff that you can mix with water if you have to travel or something like that. So it certainly is an acceptable alternative. Key is you want to advise and make sure that they stay away from cow's milk until they're at least a year old. The lactose in there is difficult for the baby's intestines to tolerate, so we definitely don't want cow's milk until a year old. The postpartum state which is obviously after delivery, can take some time. It really takes a full year for the body to really get back into the normal, the blood volume and all the body parts getting back to where they're supposed to go. So it takes almost a full year, and hormones to settle down. And obviously that can be prolonged if someone is breastfeeding. The period can sometimes be delayed or non-existent if a woman is breastfeeding. The hormone prolactin that's elevated during breastfeeding can inhibit estrogen and inhibit the cycle, so some women won't have a cycle until they stop until they stop lactating. Others will get one. It's kind of varied. It depends on the person. The uterus will continue to shrink, and it does do that a little bit faster if you breastfeed versus if you don't, but it can take up to 6 weeks for that uterus to shrink, and there can be some sort of post-uterine contractions that you feel with that. There's also a postpartum bleeding period called lochia, and that can last anywhere from 4 to 6 weeks. It can be kind of heavy. If somebody comes in with really foul-smelling lochia, that could indicate that there's an infection, so that's sometimes an important thing to ask about. Women that have C-sections, prototypically, because they kind of go in and clean everything out, sometimes won't bleed as much as someone that has a vaginal delivery, but I've seen that vary a little bit. Bowel movements and urination can vary as well too. It takes time for the bladder to kind of rebound back. It takes time for the intestines to get back to normal, so constipation and diarrhea can continue, as well as sometimes difficulty urinating. So that postpartum period is always important to ask about urinary issues. And obviously stress, because now we have a person who either is having their first child, and that can be a big emotional stress, or someone that maybe had another 1 or 2 children at home and now have a third baby, and that can pose stress as well. And so making sure that the medical assistant asks how they're adjusting, how they're doing, gives a postpartum guide, and then there's usually you'll do a 3 or 4 week postpartum exam. Other places will do a 6 week. You always want to do follow-up blood testing on anemia. Sometimes they might have to redo a pap smear. And you also, if somebody has diabetes, you're going to want to do a 2-hour GTT, 2-hour glucose tolerance test if that person had diabetes. So there's quite a bit to educate on, and then assisting with any specific exams that might need to be done. When we're looking at some of the testing procedures in this setting, obviously a pregnancy test, don't ever hesitate to do one. That's why it's always good to ask what the LMP is. If it's late, you always want to order one. The book says to do a first morning specimen. That is nice because the hormone can be a little bit higher when you're doing a first voided urine. It isn't mandatory. You can do a random test any time of the day, but if someone is early on in the pregnancy, it might be better to get a first morning one, but prototypically that's not always feasible. There is a blood test for it, but the blood test and the urine test are pretty much a similar testing cartridge, and they pretty much detect. You don't really get any benefit from doing a blood test versus the urine. The urine tests are very sensitive and can detect the human chorionic gonadotropin hormone is as low as 25 micrograms of hormone, which is about what the blood test does. So it really doesn't do any advantageous benefit to do a blood test unless you're dealing with someone that might be having a miscarriage. Then you have to do serial blood tests for that, so it's a little different. But the blood test versus the urine test is pretty comparable. Sexually transmitted infection testing can be done either, usually we'll do all of that in the first visit. If there's any indication that maybe the person is symptomatic, you might have to repeat it. Lesions would be an issue if somebody had herpes. Now, syphilis is something that's tested for automatically with everyone with the initial blood testing as well as hepatitis screening. If you get syphilis during pregnancy, there can be serious consequences with the baby. And so that is one of those routine things that is done right off the bat. If anybody were to get lesions that might be herpetic, that needs to be examined as well. If someone has herpes, you can have a normal pregnancy and a normal vaginal birth, but usually they will give you antiviral medication during the last month from 36 weeks to delivery. If someone were to have a suspected or questionable lesion during that last month, they would usually opt to do a C-section. You can't pass an infant through the vaginal canal if there's an active lesion, because there can be serious consequences with that fetus. And so if you can go the whole pregnancy without any lesions, then you can have a normal vaginal birth. But if there's any question of symptomatic lesions, then a C-section might be indicated. Okay. Certain sexually transmitted infections need to be reported to the state, and it's called a county morbidity report, CMR, or an M&M report, where it's a morbidity and mortality. Chlamydia, gonorrhea, hepatitis B or C, syphilis, HIV, need to be reported to the state. And so anybody that contracts that infection or has a positive test needs to be treated. And there's paperwork that needs to be filled out and faxed in to the county. And so it's important to know that. Some physicians forget to do chlamydia reporting because that's probably the most common infection. But that needs to be done. It is a state law. Trichomonas and herpes are not reportable, but all the other ones are. And so what I frequently do, our system is hooked up to our CMR report, fill it out, and then usually we print it out, and then it has to be faxed into the state. So there are certain radiologic tests that we can look at. X-rays we generally avoid when you're pregnant because the ionizing radiation is not a good idea, especially in the first trimester. So we generally try to avoid X-rays, dental X-rays, unless it's absolutely necessary. The one time we will do an X-ray is if a patient has a skin test, a PPD, screening for tuberculosis. We always try to do one of those. There is a blood test now, but we generally do some form of screening for tuberculosis. If it's positive, then at 20 weeks with an iron apron over the stomach, a single AP shot is done to make sure that there's no active lesions in the lungs or active disease in the lungs. You can't have a patient that might have tuberculosis going to a hospital. That would not be good. So they wait till 20 weeks when the neurologic development is done. They cover the abdomen and then do a single shot. If it's clear, then that patient would be offered possible medication depending on the scenario after the baby is delivered and after breastfeeding, but it depends on the scenario and depends on the patient. Ultrasonography, definitely done. Usually you have at least 2 done during a pregnancy. There's a routine one done in the first trimester, generally to confirm date sizing and dating. And then a second one is done around 20 weeks to do a full a full anatomical screening. If someone, there's some other blood testing that we talk about when we're doing fetal screening. If someone has a positive AFP or is over 35 or has some other risk factors, they can do a level 2 sonogram, which is a more thorough ultrasound compared to just your run-of-the-mill anatomy screening, and that can look for certain markers that might indicate Down syndrome or what have you. Prototypically, we don't do CAT scans and MRIs during. CAT scans are high radiation, so we don't generally do those during pregnancy. MRIs maybe, but prototypically they'll try to hold off on an MRI as well. Hysterosalpingiography is acronymed HSG, and there are case scenarios. We don't usually do that during pregnancy, but if someone has a patency issue in their in the fallopian tubes, if they have difficulty getting pregnant, you can inject a dye up through the cervix into the uterus, and that dye can then travel through, and you can see whether or not there's scarring or blockage. There's a new birth control method called Essure, where you actually put a coil inside each fallopian tube, and then they'll do a hysterosalpingiogram 3 months after that to make sure that both sides are occluded and that that person can't get pregnant. So hysterosalpingiography can be used. We talked about mammograms a little bit already. It's important to know these tests because they're very common in pregnancy, and so being able and capable of scheduling appointments and being able to deal with all the instructions. There are some mammogram instructions, and they're listed in the book. That's important to discuss with that patient. Okay. There are certain lab tests that need to be done when you're looking at fetal screening as well. Some things are routine, other things are for at-risk pregnancies. The alpha-fetoprotein is generally, they split that into 2. It used to be one test done between 15 and 20 weeks, and it was a screening test for trisomy 18, trisomy 21, which is Down syndrome, and any type of neural tube defect. Now they've actually gotten a little more sophisticated, and they have an AFP1, which is done between 9 and 13 weeks, and then an AFP2, which is a follow-up that's done between 15 and 20. And then if there's any abnormalities with those, then they'll generally do a level 2 ultrasound sometime between 16 and 20 weeks, and then they would offer that patient an amniocentesis. And an amniocentesis is where they actually take a probe with an ultrasound guidance into a pocket of amniotic fluid within the uterus and try to pull out that, and they can actually get a karyotype and actually see if we're dealing with either a neural tube defect or one of the other things that you can be detected on an alpha-fetoprotein. Okay. There is something called chorionic villus sampling, CSV. That is actually for people that have had kids or individuals that have known genetic disorders in their family or have had children with genetic disorders. And that can be drawn a little bit earlier, between 10 and 12 weeks. Usually a perinatologist is going to deal with that. Most of those people will be seen by a specialist, which is a perinatologist. That's not a routine thing to do, but if someone has any of those issues, then a CVS can be done. Your normal routine ultrasound for anatomy done at that 18 to 20 week time frame is going to be looking at fetal size as well as fetal position, any markers that might indicate that there's some sort of genetic issue, looking at the position of the placenta. That way you can tell if there's a previa, make sure the placenta is adhered and developing normally. And then you'd also could look for any kind of fibroids or cysts on the ovaries, but primarily you're looking for fetal size and position. Okay, so that kind of covers gynecology and obstetrics. We'll talk a little bit about STIs at the end. So now we'll go to assisting in urology, and there's a lot of medical assistants in this specialty. The urologist diagnoses and treats female urologic disorders and diseases, as well as males, as well as the male reproductive system. So it covers all of them. They're not usually, urologists are usually both male and female. They don't just specialize in one gender or the other. So the medical assistant, very similarly to gynecology, would assist with exams, collecting and processing urine. The urinalysis is the most common test done in the urologic setting, as well as, very common in gynecology as well. Okay, so patient education regarding, we'll talk a little bit about the testicular self-exam is important. And some of the other patient education settings issues as well. So when you're looking at questions or guiding your HPI in urology, you are looking for urination patterns, so things that are associated with that: frequency, urgency, dysuria, nocturia, incontinence. Incontinence is the involuntary loss of urine. When you're looking at females, they can have a stress incontinence, which is weak muscles, or they can have an urge incontinence, where it's a feeling to go immediately and they can't hold it, and they'll sometimes pee themselves or urinate on themselves. And so those are common questions. When you're looking at the male, you could be dealing with a STI or an epididymitis or a prostatitis, which could be a bacteria that gets in there, gets up inside one of those organs and causes inflammation or infection. If men have incontinence issues or decrease in their urine stream or frequency or even nocturia, where they get up at night more than they should, that can all be signs that maybe there's a prostate issue. And so when we're looking at the exam, we're generally looking at the urethra and the bladder and the surrounding organs with that. For both females and males, you would do an inspection of the external genitalia. In males, you're going to want to palpate not only the penis, but as well as the scrotum and then the testicles. And there is a page in there that talks about testicular self-exam. It kind of gets overlooked. We do kind of focus more on females, but testicular cancer, the age for that is like 18 to 20 or 18 to 30, and so somewhere in that bracket. And so men don't realize that they're at a high risk at that age bracket for testicular cancer. And so it's important to do a testicular exam, because you'd want to detect something as soon as possible if that's going to be an issue. When you get to 40, prostate cancer tends to be more of the problem, and so doing prostate gland exams on men over 40 are important, and we kind of discussed that a little bit. In class, the TSE is the testicular self-exam, and there are patient instructions on how to do it. The clinician should check a male that's coming in with that, but advising males on how to do that check is important. So thorough history, once again, all of the patterns, urinary patterns are important. Difficulty or pain, incontinence, any nocturia should be kind of in there as well. When you're looking at the organs involved, you're looking at the urethra and the bladder. However, some of the tests that urologists will order will also involve the ureters and the kidneys. And so sometimes they'll do a pyelogram or something or a KUB that actually, which is an x-ray of the kidneys, ureter, and bladder. Sometimes urologists will actually involve the kidneys. Now, if someone has pre-existing kidney disease or diabetic nephropathy or hypertensive nephropathy where they actually have kidney issues, they will usually work in conjunction with a nephrologist, which is a kidney specialist. But the urologist, the kidneys are involved with that, so sometimes the urology exams will also involve the kidneys, although they are primarily looking at the urethra and the bladder. You also have to inspect the external genitalia, both male and female, when you're dealing with this. And when you're looking at the male reproductive system, you have to inspect, palpate, as well as demonstrate and show that testicular self-exam. Some of the tests that might be ordered, CAT scan and MRI might be. Pylography is where they actually are checking the kidney function, and that can be a situation where they actually go up through the urethra and go all the way through the bladder, through the ureters, all the way up to the kidney. Urinalysis, once again, is your most common test. Blood test that might be ordered, a PSA is a common blood test. If you're checking the prostate, sometimes the prostate will have an elevated PSA test, which is a prostate-specific antigen. If that's elevated, that could indicate that there's issues with the prostate. Semen analysis can also be done as well, and so we can evaluate, determine fertility of a male, and prototypically this is the first step in a fertility workup for a female. If you're in a relationship and you have a male and a female, and or whatever situation you may have, they'll usually send the male for a fertility workup or a semen analysis first. It's the cheapest and easiest first step to do. If that's the issue, you don't have to go any farther, and it saves a lot of money. If the fertility count, or the semen analysis count is normal, then you have to systematically and stepwise go through the process of figuring out why that female can't become pregnant, and then you can do certain stepwise processes. But prototypically, the semen analysis is done first, and it's also used after a vasectomy is done. So the male procedure of sterilization is a vasectomy, where they go in and cut the vas deferens, and so you have to do a post-semen analysis to make sure that that procedure was successful. Two other tests that are frequently done in the urologic setting is cystometry and cystoscopy. And cystometry is measuring the bladder capacity and pressure, and if somebody is having issues with urgent incontinence, or maybe they have multiple sclerosis, if there's some nervous intervention, they'll have to measure those things. Interstitial cystitis, any type of situation where maybe the bladder capacity or the pressure is off. A cystoscopy is where they actually take a camera, go up through the urethra, and then check the bladder, the urethral walls and the bladder. If somebody had, once again, interstitial cystitis and they needed to check the walls, or even a bladder cancer, somebody comes in complaining or has microscopic hematuria or gross hematuria even on a urinalysis, and there's no pain with it and it's not an infection, then they have to start kind of looking for bladder issues. Or a kidney stone can also cause that, but you'll also check, you'll have to check the bladder. They'll do a scope, they'll do cells in the urine for cytology to see if there's any cancerous cells, and then do a scope and see if there's anything going on. So that's a common test to do. And then if a TSE were to be positive, or the clinician were to find a lesion or a mass or an enlargement of the testicle, then they would have to do a tissue sampling, so you might have to do a testicular biopsy. So the next couple of slides talk about some of the diseases and disorders of the reproductive system. Obviously, when we're looking, this first page, this first thing involves female. When we're looking at female conditions, the first one says cancer, so obviously we could have cancer of the cervix, endometrium, which would be uterine, or ovaries. This is where cells in that area divide uncontrollably and eventually form some sort of tumor or growth. Pap smear can detect cervical cancer. Endometrial biopsy can detect uterine cancer. Ovarian cancer is a little bit tougher to see and to diagnose. Generally, cervical and endometrium have some sort of bleeding or pain issues with it, and you can actually detect those earlier. Ovarian cancer can be, there's less cases per year of it, but it can be a little bit more insidious and a little bit slower growing. And so a lot of times you might have abnormal bleeding patterns or pain or sided pain, but sometimes by the time you actually get symptoms, things have kind of progressed. And so just making sure that you get your routine exams, and any kind of changes in pain or bleeding pattern, make sure that you get checked. Ectopic pregnancy is actually where a fertilized egg gets stuck in the fallopian tube and can't migrate to the uterus for implantation. Now, fertilization actually takes place in the tube. Okay, that's what happens. We don't actually have fertilization in the uterus. So we get fertilization in either tube, and then the egg must be able, that fertilized egg must be able to travel and migrate and then implant in the uterus. And if there is scar tissue from whatever reason from a previous STI like chlamydia or something, then that egg can get stuck and then fertilize in the tube, and you can only get about to 6 to 8 weeks and that thing will rupture. And so any kind of bleeding or sided pain during the first 6 to 8 weeks of a pregnancy, we always have to think about an ectopic, okay? And so that's always something to rule out. Endometriosis is it's not a very common thing, and it's not life-threatening, but it can cause sterility and it can cause a lot of pain. And so what ends up happening in endometriosis is you get endometrial tissue located, instead of being inside the uterus, it starts to adhere to the outside of the uterus or on the pelvic cavity. And so that can cause pain with periods, pain with intercourse, heavy bleeding, bleeding in between periods, and so it can be, and it can lead to infertility issues as well. And so the problem with it is the only way to diagnose it is to do a laparoscopy, where they take a scope and look through the belly button. That's the only way to diagnose it. There are some new medications on the horizon for this. Sometimes birth control pills help, sometimes they don't. If nothing works, then they can do an exploratory lap and then do some laser therapy to take care of it. But it's sort of what we call a diagnosis of exclusion. We have to rule everything else out, and then we can go to when somebody has chronic pelvic pain, and then go to the exploratory lap if it looks like we're dealing with endometriosis. The next two things are very common in the gynecologic setting: fibroids or leiomyomas, and then fibrocystic breast disease. Fibroids are extremely common. Over 40, it seems like the uterus just likes to start to change a little bit, and you get these benign smooth tumors in the muscles, in the muscle cell or in the smooth muscle of the uterus. I diagnose them all the time, and most of the time they're not cancerous. They don't break off, they don't metastasize, but they can get large. They can put pressure on the bladder or the intestines or other organs. They can cause increase in bleeding, pain with intercourse, bleeding in between periods, and so sometimes you can, if you find one and they're small and you're asymptomatic, it's no big deal, but sometimes we have to go in and do a fibroidectomy, or sometimes if it's significant enough, they have to do a hysterectomy and pull it out, depending on the scenario. But they are not cancerous, and there are times where once you hit menopause, they'll shrink and go away. So we just kind of deal with it symptomatically depending on the patient. Fibrocystic breast disease, same thing, very common. These are benign breast cysts. They're usually fluid-filled. Sometimes they're nodular. Some women, they're usually symmetric, and there's no reason to pull them out. They used to drain them or remove them, but they would sometimes come back. They're not dangerous, although they do tend to be kind of sensitive to caffeine consumption and salt. And so if you do have fibrocystic breast disease, generally you'll get a lot of breast pain with ovulation through getting the period. That second phase of the cycle will sometimes cause breast pain. So if you are sensitive to it, increasing fluid, staying away from salt and caffeine can sometimes help. Birth control pills, something that controls the hormones or decreases the period, can be helpful as well. But they don't increase the risk of breast cancer. They don't change into breast cancer. And symptomatically, you just kind of deal with it as they come across. If you have a lot of fibrocystic breast disease, the only issue is that if something cancerous came up in between there, it might make it a little bit harder to diagnose. So that's the only issue, but they don't ever change into it. There's a couple of terms that are listed here that have to deal with menstrual disturbances. You'll see these as diagnostic codes. Amenorrhea means lack of a period. Dysmenorrhea means painful menstruation, and then menorrhagia and metrorrhagia are usually heavier bleeding or bleeding in between your cycles. And so those are frequently used depending on what symptoms are present. They are diagnostic codes, so it's just important to be able to recognize them. Sometimes you'll see oligomenorrhea, which is bleeding at less cycles, like every 2 to 3 months. So that's another one that you'll see, but it's not listed there. Ovarian cysts are also very common too. They have a tendency to be a source of stress, and females, they'll panic and freak out because they have an ovarian cyst. most of the time, ovarian cysts are normal. If they're small, fluid-filled, simple, and not complex, they'll sometimes pop up on the ovaries, and the thing is that as an ovary goes through its cycle process of forming an egg and then releasing it, it has to form a small cyst. And so sometimes if the egg doesn't burst through, it'll form a little cystic formation, and then it'll sit there for a little bit, cause a little pain, and then it'll rupture and go away. So most of the time, cysts under 2 centimeters aren't a problem. If you start getting something that's 4 centimeters or bigger, the risk is that if it's fluid-filled and or blood-filled, then if it were to rupture, it could kind of bleed inside and be kind of an issue with that. Overall, the ovarian cysts are not anything to worry about, but size does make a difference. A lot of women that maybe have something will put them on birth control pills and see if we can't shrink them. If they get really large, sometimes you have to go in and drain them. If something is a complex cyst or multiform, sometimes that could indicate that it's more serious, and a lot of times they'll biopsy those. If someone has a lot of what's called follicular cysts, where you see multiple small cysts on one or both ovaries, that can indicate polycystic ovary syndrome, and that can be something that's related to insulin resistance, the potential for becoming diabetic, and those women do tend to have amenorrheic cycles or oleomenorrhea, and it can be a little bit more difficult for them to get pregnant. PID is a pelvic inflammatory disease that can happen secondary to a sexually transmitted infection like gonorrhea or chlamydia. So if someone has an infection, it's important to get them treated, because this can happen and it can cause tremendous scarring, and it can lead to infertility later on. Pelvic support issues are one of those things where you start having, when you start going through menopause, if you've had multiple births, you can actually get a weakening in the vaginal walls. The musculature can get weak. This is a situation where you have to start recommending Kegels exercises. Sometimes they have stress incontinence. There are some measures to take if people have this. There's some physical therapy and something called a pessary that can be used. But that will be in a complaint, especially when you're dealing with menopausal age. Polyps are little kind of slender on the mucous membrane, sometimes on the cervix or inside the uterus. They can be a source of bleeding, but we do kind of prototypically find these periodically. We usually remove the polyps just to be on the safe side, but most of the time they're not cancerous. PMS and PMDD are very real entities, and it kind of goes through and tells you what you're dealing with. Sometimes these women do need to be on either birth control pills and or antidepressants, depending on the scenario. When you actually find swelling, bloating, weight gain, breast tenderness, all of those things are very common right before the period starts, and sometimes it can cause women to be cranky. Then there's a small percentage of those people that will actually have premenstrual dysphoric disorder that's actually much more severe, and so those women do need to be identified and treated. Vaginitis is also very common, where you actually get imbalance in the bacteria in the vaginal area. It's called bacterial vaginosis. But things like douching and tampons and spray, different chemicals and soaps that have fragrances, you want to stay away from that. Women don't need to douche. Their body has, the cells in that area can secrete some, are secretory and can create a little bit of discharge, and so the body is sort of self-cleansing. Douches are not necessary. That can actually lead to infections. And then we deal with these last, the epididymitis. That's an inflammation of the epididymis, and that can usually be bacterial in males. Hydroceles are where you actually get a little bit of fluid or excess fluid in the scrotum. Those can actually be quite painful, and so sometimes those need to be drained and dealt with. Okay. Incontinence can be male or female, and I kind of already touched on incontinence. That's where they actually lose bladder control, where either weak muscles or urge incontinence symptoms. In females, it is called urinary incontinence, and it's important to know if that's going on, because if you're doing a urinalysis or what have you, it needs to be documented. If men are having it, they could be having prostate issues, and so it's definitely an important question with males or females. Kidney stones can occur in males or females as well. Generally, there'll be some sort of crystallization. It's mostly calcium, but there can be other things that crystallize and form. And if they get stuck anywhere between the kidney all the way down through the ureter or the bladder, you can get a lot of pain with that. And so urologists, as well as nephrologists, will oftentimes deal with kidney stones. We kind of already talked about prostatic hypertrophy. When we're dealing with prostatic hypertrophy, we're dealing with a benign enlargement of the prostate gland, very common in men over 50, but they can have constriction of the urethra, so they'll get decrease in their urine stream, urgency, nocturia, and it can be an issue if it kind of closes off the urethra and you can't get the urine out. That can cause significant issues. So it's they used to do prostatectomies where they would take partial or parts or the whole prostate out, and men were becoming incontinent as well as impotent after that. They had erectile dysfunction because of it, and so there's some new methods out that they're utilizing as opposed to doing that. But you'll still see people that have had what's called a TURP, and they've had their prostate transected, and they will sometimes have urinary issues as well as impotence issues with that. A prostatitis is just where the prostate gland becomes inflamed. It's usually bacterial. These people will sometimes need antibiotics. Sometimes it could be something sexually transmitted, but more than not, it's just another kind of bacteria that causes it. Urethritis is inflammation of the urethra. That is usually bacterial as well, and those guys will present with pain with urination or dysuria and a penile discharge, and that's usually sexually transmitted. Okay. Prostate cancer, more common in the older sector of men over 50. A lot of times they don't have any specific symptoms. So that's why males, when they go in for their, starting at 40 with their physicals, getting a prostate exam, and we talked about the position they'll frequently need to be in order to have that done. Generally, they'll do what's called a PSA first. That's a prostate-specific antigen. And if that's elevated and there's an abnormality in the contour or consistency of the prostate with any masses or hard areas, and it could indicate prostate cancer. And the last little thing talks about sexually transmitted infections. Please make sure you read over the table, educating the patient, teaching patients about sexually transmitted infections. That's a really big issue, both male and female, making sure that the more they hear it, hopefully the higher the chance they'll have of abiding by all of the things that they need to do to decrease their risk of coming up with something sexually transmitted. It can be very sensitive, especially when you're dealing with patients that have been married for a length of time, and then suddenly one of them pops up with an infection, and it can be very much a surprise to the one that hasn't been with someone else, and so it's a very touchy situation. So patient privacy is huge. Always make sure that if there's any results being discussed, that you're behind closed doors. You generally don't have to be the one that's giving that information. The clinician will, but you're going to have to explain some of the things that are on page 791. Completing the course of therapy is important, and a lot of places will administer the therapy in the clinic, and you can actually physically watch them take it. Chlamydia, azithromax, usually it's 2 tablets. It's at 1 gram, so they either give 4 tablets at 250 or 2 tablets at 500. There's a liquid that can be drank as well, a powder that can be dissolved, and then if they're being treated for gonorrhea, there's an antibiotic or a shot. Rocephin is a common combination with Zithromax to treat that. And so a lot of times they'll be treated before they leave. The important thing is to make sure that they get their partner treated. We have lots of cases where people get treated in the clinic and they don't tell the partner still has it, and then they wind up getting it back again. And so sexual partners must be treated. You must avoid sexual contact until all the partners are treated, or however the situation is. But that's a big thing. Condom use until the recheck. Most rechecks for gonorrhea and chlamydia are in 3 months. And so generally you want to do a recheck and make sure that both parties are clear, and then you can usually stop using condoms, at least as far as, that particular infection. Okay, but the guidelines teaching patients about STI infections and how to prevent them and how to keep them safe is important. All that information on page 791 would be important to read through. Okay. All right, so we covered a lot, talked about obstetrics, gynecology, breast issues, Pap smears, how to assist with pregnant females, all the patient education that goes along with females as far as being gynecologically related, obstetric related, there's a lot of the testing that's involved with that, the urologic testing for males and females. And so there's quite a bit here. And once again, at least a few of you will probably wind up in a gynecologic setting. And once again, urology is becoming a popular setting as well. And so it's important to be familiar with the information here. And plus it overlaps with a lot of things that are done in primary care as well. Okay. All right, so we're signing off with this particular chapter, and then the next chapter you'll need to do for this section is chapter 40 on assisting in pediatrics. Okay.